Hi everyone. Thank you so much for being here. We're just going to start as it's 1 o'clock. My name's Adele and I work at A1 Momentum. And we're just really thankful that you're all here today on the webinar that is on dementia care, effective positioning, helping to reduce falls, distress, and pressure injury risk. So it will be Kirsty Ryan who will be leading the webinar today. And she is an occupational therapist and clinical training manager at Seating Matters. She is currently doing a doctorate at the University of Limerick as well and studying to do that. But she is she's massively passionate about dementia care, and she has a wealth of experience in that area. So we're just really excited to hear what she wants to say today. The webinar will be recorded, so it's being recorded at the minute, and then a copy of that will be sent out in a post-webinar email to yourselves, and a link to the live recording. There will be a Q&A at the end, so if you have any questions for Kirsty or anything we can help you with, please pop them into the Q&A box or just the chat box, and we'll try our best to answer them at the end. I think that is everything. So Kirsty, if you're happy enough, I'm happy enough to hand it over to you.
Perfect. Thank you for that introduction, Adele. And thank you all for coming here today and joining us. This webinar really would be based on my experience and how I work with people who have dementia and what I find works really well. But I'll also be drawing on the evidence and the research to help support what I'm going to be talking about. So for those who do not know me, I am Kirsty Ryan and I've worked with City Manners for about 3.5 years now. Before that, I was working in community as an occupational therapist, and before that, I was a mental health nurse working in residential and acute settings. So I think the reason why I talk about this a lot at masterclasses and conferences, but the reason why I changed from nursing to OT is because I had my own personal experience working with an occupational therapist. I had a serious car accident where I broke my neck and I got a brain injury. And because of that occupational therapist, I decided to pursue OT myself. And do I not have any sound, Adele? Can you hear me? Someone just said I don't have sound.
No, you're totally fine. You keep going. You're all good.
Okay. Yeah, so because of that, working with that OT, I decided to pursue OT myself and help others, just like that OT helped me. So OT, I think, is so powerful, and we can do amazing things for patients and really help their recovery and if in my case, their life path. So I have worked a lot with people who are living with dementia, and I've worked in acute and residential settings. And lots of people saying no sound, Adele. Are we good?
You're totally fine. Don't worry.
I will keep going. You can deal with
You keep
that.
going.
Thank you.
Yeah.
Yeah, so I am really passionate about working with people who have dementia and helping improve health outcomes. My own grandmother passed away with a diagnosis of dementia in 2019 now. And I wish I knew then what I know now, because I think we could have helped her a lot better. So I'm hoping that this information will help you and will help the people that you're working with. Great, you can hear me. Thanks so much, guys. Okay, so let's just look and start off by looking at what is dementia. And dementia is an umbrella term for a range of progressive disorders that affect the brain. And there are over 200 different types of dementia. Alzheimer's disease being the most predominant, 50 to 70% of diagnoses make up Alzheimer's disease. And in the UK, there's a large proportion of people who do have a diagnosis of dementia, 982,000 people at the moment. And research tells us that 1 in 3 people born today will go on to develop dementia later in life, which is crazy. And we know it's very expensive to treat and to manage. And when it comes to dementia, if we look at the MRI scans, we can see the shrinkage in the brain occurs. And this shrinkage, the area of the brain that has the shrinkage is affecting really depends on the type of dementia that person has, where that shrinkage occurs. And so the shrinkage can occur in the subcortex, it can occur in the cerebral cortex, in the brainstem, it can be global. This shrinkage in the brain then will mean that there are symptoms that go along with that cause these symptoms. And there's a whole range of symptoms. We won't get into all of them in this webinar, but the symptoms can vary from person to person. But some of the common symptoms can be things like difficulties with maintaining a good posture, body awareness, memory, difficulties with problem solving, hyposensitivity or hypersensitivity to touch, to movements and to environments. So things that are hot, they might perceive these as being very hot, or something that just touching the person's skin, they might perceive this as being very painful, for example. There can be difficulties with peripheral vision, so the outsides of what the person sees, that can become reduced. And it can even lead to monocular vision, which is using just the one eye. And it can lead to difficulties with depth perception as well. So things can be further or closer away than they actually are, which obviously will affect their ability to engage in functional tasks and increase the risk of falls. Difficulties with pattern recognition, so lines or dots, they could see these as moving on the floor, or they could perceive a circle shape or a different colour on the ground. They could perceive this as being a hole and be fearful of that. This shrinkage in the brain, it can lead to sensory motor disintegration. What that means is it's shrinkage of the sensory cortex in the brain and shrinkage of the motor cortex in the brain. So let's just have a look at those. Shrinkage of the motor cortex can lead to difficulties with coordination. So moving their limbs as they wish to move their limbs. Difficulties with dexterity and those fine motor movements, so picking up cutlery or doing up buttons, they can find that quite difficult. This shrinkage in that motor cortex can lead to difficulties with the ability to swallow, so having that movement in their throat and moving their face and their tongue. So when we are helping somebody with feeding, for example, and the person is not able to move their mouth and not able to swallow very well, we can understand why they might be reluctant to feed, because they're fearful of choking, and we can understand that. But then shrinkage of the somatosensory cortex, that can lead to reduced sensation in the plantar side of the body. So by that we mean the back of the torso, the back of the head, the back of the legs, the soles of the feet, and the palms of the hands. Sometimes we do see that person who has dementia and they'll have their fists clenched really tightly. They're looking for that sensory feedback. They also have reduced sensation in the lips and the oral senses needed for feeding. So not only can they not move their mouth very well, but now they can't feel it very well either. So we can understand why somebody might be reluctant to feed. This person here, they're presenting with something called paratonia, and you might recognize this in your practice. But what this is it's defined as a form of hypertonia. So it's high muscle tone with involuntary variable resistance against passive movement. So involuntary, she cannot help that high muscle tone. And it's variable, so which means sometimes it's there and sometimes it's not. And that can oftentimes get confused with a behavioural issue, a behavioural symptom. But we know that she can't help that. That's involuntary. And this degree of resistance depends on the speed and the force of the movement. So if you're helping somebody with dressing and you feel them resist, that resistance, the amount you feel of that resistance, that depends on how fast you're doing the activity and how forceful you are. It's amazing because 90 to 100% of people with late stage dementia will have paratonia. 90 to 100%. That's a huge amount of the people that we care for in dementia care have paratonia. And you can see the way that she's presenting there. She's got those flexed arms and the flexed legs. And she's got her back extended and her head extended. And she's exerting a lot of energy to maintain that high muscle tone, holding herself tight. She's holding herself tight so that she can feel where her body is. And those bony prominences like the knees and maybe the ankles and the wrists, they're pressing hard against each other, increasing her risks of developing pressure injuries. But if we can imagine holding ourselves tight in that position for a long period of time, that's going to increase our risks of developing fixed postures and contractures and limiting that range of movement. Not to mention how painful it must be to sit in that posture for a long time. Every movement that we make, every time we help her with dressing or washing, she's suffering immense amount of pain and discomfort. But what we know is there's things that we can do to help this, or at least slow it down. We can use 24-hour postural care. There we go. Sorry, my slides just got stuck. There we go. 24-hour postural care. So we want to sensory inform the body. So we want to use pillows and use supports to give that proprioception, that sensory feedback, so that she can feel her body and start to reduce that muscle tone. We can put supports behind the knees there, you can see in the photo, and that reduces the amount of flexion that she can do. So reduces the amount of flexion, and then she has a better range of movement with her legs and maintains the amount of range of movement that she has. So this is a lady that I saw last year, and this is a chair that she had for 2 to 3 years. And this is a great example to show that how we lie affects how we sit. So she is in the exact same posture in the bed as she is in the chair. So she's sitting in that same position 24 hours a day. And unfortunately, what happens is if we don't do anything about it, it will just get worse and worse and worse. And that flexion will continue to get worse. And here is an after picture when I assessed her and I issued her with the Atlanta chair. So with the Atlanta chair, you can see she has much better contact with the chair. You can see that the way that the legs are able to be accommodated back behind the knees to allow for that flexion. We actually reduced the cushion and the pressure cushion so that it would accommodate that flexion in her legs. You can see, however, I do acknowledge that the left foot is not in complete contact with the foot support, but bear in mind that this is the first time that this lady has sat in a posture that was not her previous posture. This is the first time she sat in a chair like this for years. So it's really important that we understand what we do in the chair, we have to do in the bed as well. Because all that great work that we're doing in the chair will be undone when the person's in bed for 8 or 10 hours. And if she's not supported in the bed, then those postures are just going to continue to get worse. This is a paper that I found, which shows that using those supportive cushions in bed, it can help reduce muscle tone for people with paratonia. So we can see that this study here, the interventions of using those supports in the bed, it was implemented over 1 week with measurements taken on 3 separate days. In the study, they assessed muscle tone, they assessed range of movement, they assessed the patient's pain and discomfort, and they used all different assessment tools, which I can share with you if you wish. But you can see in the picture, you can see now that's an example of how they position somebody in the bed. The results of this paper showed that supportive cushions in bed significantly reduced muscle tone and increased elbow extension after just 30 minutes of positioning. So you can see there that the cushions were placed to support the head, support the arms and the legs, and eventual rotation of those legs and spine to one side was neutralized by using more supports on one side, because we know people who have paratonia, oftentimes they'll lie in a fetal position in the bed, which will continually get worse, and they'll continually flex their legs. So we want to make sure that we are giving them the supports to reduce the amount of flexion that they can exert. Cushions was also placed between the legs there to reduce the amount of pressure at the knees. And when you are applying these supports in the bed and in the chair, it's always important that we check in with the person. If they're verbal, great, we can ask them, Is that okay? Have you any pain or discomfort? If they're non-verbal, we have to check in and make sure that we don't see any kind of facial expression to show us that they're feeling pain or discomfort. Speak to the families as well, because and the caregivers, they know them best, and they'll be able to identify those faces and changes that they make when they are feeling pain. So that's exactly what I did with this lady. She was in the bed in this position, and I gave her the Atlanta chair, but I also made sure that I gave her bed supports as well. This is something that I think that I'm really excited to be able to talk to people about, because I don't think there's much attention given to this subject. Passive mobilization exercises. I know when I first qualified and was working in residential care, this was something that I brought to my managers, and at the time my manager said passive mobilization exercises, that's what we should do for people who have those reduced range of movements at their limbs, especially those with advanced dementia. And I'm ashamed to say, but that's what I used to do, because I didn't know any better. I used to recommend passive mobilization exercises. But this is a study here from 2011, and it shows that this is not what we should be doing for people with paratonia. This study talks about passive movement therapy, and they say that it's frequently used to manage paratonia, but its effectiveness really hasn't been significantly shown. This study investigated the effects of passive mobilization exercises on muscle tone. And what they did was they got 101 nursing home residents with dementia and moderate to severe paratonia across 12 nursing homes. Participants were randomly assigned to receive these exercises 3 times a week for 4 weeks, and they were split into groups. So some people were getting these exercises, and they had a control group as well that had no passive mobilization exercises prescribed. They used outcome measures like the modified Ashworth scale, and also they looked at the clinical improvement scale, caregiver burden, and also pain during the morning care. So they assessed that using the pain assessment checklist. They assessed a baseline and then 2 weeks and then 4 weeks as well. But the results of this study showed that there was no significant difference between the group that got the exercises and the control group for any of those outcomes at any point. Passive mobilization exercises did not improve muscle tone. It didn't improve caregiver burden. There was no positive clinical impressions, and it did not affect pain levels. In fact, it actually increased participants' levels of pain. So I really am excited and happy to be able to share this paper with everybody, that this concludes that passive mobilization exercises provides no therapeutic benefit in severe paratonia, and it should not be recommended as an intervention in advanced dementia care, because all we are doing is we are just causing more pain and discomfort for this already vulnerable, and they're already experiencing pain and discomfort every day. So let's not make it worse by recommending these exercises, and please share this. I wanted as well to talk about falls in dementia care, because this is something that we see a lot. People with dementia in UK, they experience about 8 times more falls than cognitively healthy older adults. And in fact, around 2 to 4 falls per resident per year. In the community settings, they may have up to 10 times more falls. So falls are 3 times more frequent than in community dwelling older adults. And when people living with dementia fall from a chair, the falls often happen during transfers, like rising out of a chair or sitting down or attempting to move without help. So it's always important to realize that, when it comes to seating, when we are when the person is transferring in and out, this is the time that's most high risk for the event of a fall. And why does that happen? Well, it can be because of impaired judgment and insight. It can be because of poor motor planning and the difficulty with those motor movements. People with dementia are oftentimes impulsive, or they experience wandering, or they want to get out of the chair because they have to do something. oftentimes it's something urgent, right? Polypharmacy as well, which is quite common in not just UK, but all care homes, I think. Fluctuating mobility as well. You know, we all know that sometimes the person can stand absolutely fine, and other times they need more assistance. And the risk of falls is increased, especially where this insight, motor planning or judgment is impaired. So prevention, when it comes to chair-related falls, should definitely include things like more supervision, appropriate assistance as well. We should make sure that we assess the transfer method and make sure that that's appropriate and they have the equipment that they need, and a documented falls plan tailored to the person's mobility and behaviour. So when it comes to putting on the slings and using in situ glide sheets, I think it's really good to use in situ glide sheets when working with people who have dementia, especially paratonia. Those in situ glide sheets, they can help reduce the friction and unwanted rolling when repositioning a person, reducing the risk of those pressure injuries and any kind of injury to the skin, especially for someone who is agitated or you find quite difficult to move. Them in situ glide sheets can really help. They can also help us, the caregivers, because they reduce the physical strain on the staff and improve comfort for the person being handled as well. So it's a win-win. Glide sheets, they can also support sling insertion. So helping carers put the sling on with less rolling and less manual force, making it much easier, much more comfortable experience. We all know when working with people who have dementia, sometimes they can get quite distressed when we're inserting and removing the sling or when we're using the hoist. So making that experience as easy as possible for everyone involved will really help. It can also be quite difficult to actually insert the sling properly when the person's sitting in the chair. I think we've all experienced this where it is difficult to get the sling on, and it's definitely more difficult to get the sling on properly. So in situ glide sheets can really help, and in situ slings are really, really good for this, especially for people who are plus size, but people with dementia as well. It reduces all that manual handling where the person sits on the all day sling and we can hook it up. Just be really careful when you are inserting or you are using one of those in situ slings. Make sure that they're not sitting on any of those seams. Sometimes those seams can be tricky and they can be in the wrong place. So make sure that the person is not sitting on the seams of the sling, making sure that the sling is obviously the right support the person needs, the right weight and the right size, and making sure that we assess the pressure care as well, because it's not one size fits all or it doesn't suit everybody. We have to always assess and use our clinical judgment. When we use in situ slings, because the sling is positioned properly when we're using them, it's good to keep the person aligned and in good position when you are transferring them into the chair. Someone with dementia may be exhibiting some behavioural issues. They might be twisting their body, they might be resisting assistance. So in situ slings can really help. Successful sling application and positioning, it depends on staff competence, calm communication, and choosing the right technique for the person and for the task. So the main message here is that chair transfers and sling application are two of the highest risk moments in dementia care. So using planned assistance and low friction handling, those aids, they can reduce falls, distress, and they can also reduce staff injury too. So this is some advice when engaging in care activities, when conducting seating assessments, or any of those day-to-day jobs that we are doing. When we were doing that with someone with advanced dementia or paratonia, or even when transferring to and from the bed or the chair, I think these tips will really help. The first thing is to reduce sensory stimuli. So that happens the minute that you walk in the door. When you walk in the door, use a calm voice, close the curtains, make the room dark as possible, turn off the telly, reduce the noise, maybe play relaxing music. This will all help the person to feel more relaxed and reduce the muscle tone before you even start. Then the next thing that I do is I provide sensory information before I commence any assessment or begin any transfer. I would put supports around the body, pillows, blankets, cushions, give them that sensory information, and I observe for the muscle tone to reduce. That will all help you when you're inserting slings or when you're caring for the person doing day-to-day care. Use single-handed care if possible. If it's just you in the room, that's great. If there's too many people in the room, that can oftentimes lead to more chaos. There could be more noise, people doing different things at the same time. You know, if you're dressing the person, just dress their lower half first. Don't dress their lower half and the top half at the same time. One task at a time. Also consider the best time. This is something that has really saved me on a few occasions. Some people actually are more lucid in the morning. Maybe it's after their medication. The sling, I think we've covered the sling, but assess suitability of the sling. Make sure if the person, if you've assessed their hip adduction or if their knees are pressing together, ensure if the sling can be positioned between their legs without causing discomfort, because I see that quite a lot. We might see the person pressing their knees together, and that can cause a lot of pain if we're inserting the sling between the legs. So if the person you're caring for does show distress or discomfort, assess suitability of a cradle sling or a full body sling, and perhaps consider using in situ all day slings, depending on their pressure injury risk. And use the slide sheets as well when you are inserting slings, because that can help reduce the friction and the manual handling. So encourage as well the person to work with you. This will help complete the task more comfortably and more efficiently. If you ask them if they can you lift your leg? We're going to sit you up, etc. But if they work with you rather than working against you, it can help. Move slowly and be mindful of their comfort. Watch their facial expression. Ask for their verbal feedback if possible. Remember to go low and go slow. So low force and move slow, because the quicker and more forceful we are when we're assisting, the more resistor we're going to encounter. And this brings me on to the transfer. So when we are transferring into the chair, it's really important that we set the chair up first. So to set the chair up for somebody who does have paratonia, the first thing that we want to do is we want to accommodate the hip angle, and we want to open up the back angle of the chair. So open up that recline, that back angle of the chair. We also want to accommodate that knee flexion. So open, so whether that means putting the leg rests into a negative angle, which is the foot rests positioned back onto the chair behind the knees, or if we're using something like in the picture there, the Atlanta chair, making sure that there's space beneath the chair so that accommodates that knee flexion, and it will accommodate the legs to go back behind the knees. We may need to reduce the seat depth, but it just depends on the person's level and severity of paratonia. If there is severe knee flexion, make sure that there's space under the chair, and we can always reduce the depth of the pressure cushion if needed and if appropriate. You may require extra padding as well on the footrest or the foot plate to load the feet, even temporarily. Sometimes when we get the person into the chair, their feet might not be reaching the foot plate, but after time, the muscle tone starts to reduce and the feet might start to lower to the foot plate. So then you can reduce the amount of padding in that foot plate. But how we transfer into the chair is also really important. There's a technique. I think my next slide will show you that. Yeah, it's a technique. It's called the two-step transfer technique. And this is something that I use all the time, and it works like 9 out of 10 times. I won't say it works for everybody, but definitely works for the majority of the people that I see. It's a two-step transfer method using a full hoist. So the first step is you want to hoist the person from the bed and slowly lower into the chair. So making sure that the chair is set up, making sure you're using an appropriate sling, making sure that you've started that holistic approach the minute you've walked in the door to set yourself up for success. So you want to focus first on the position of the legs. So you're going to slowly lower the person into the chair. We'll take the Atlanta here, for example, because this is a chair that I use all the time. Lower the person into the Atlanta chair and focus on the legs first, making sure that the legs clear the seat of the chair. Now, that may mean that the person is not going to reach their hips to the back of the chair at that stage, but that's okay. Their hips may only get halfway up the chair on the cushion, but that's okay. If their legs have cleared the chair, you lower them down, you let them relax in the chair, you supervise, you reassure them when they're sitting, allow the person to sit and to rest. Now, this could take 5, it could take 20 minutes, but just allow them to rest, cover them with a blanket, give them supports with pillows and cushions while they're sitting. Raise the padding on that foot plate at that stage to achieve contact. But the main thing is you are observing for that reduced muscle tone in their lower legs. When their body rests in the chair and gravity takes hold, in my experience, I see that muscle tone just relax. Now, we're not going to leave them like that. Let them rest for 5, 20 minutes, whatever it takes, until you see the legs start to lower to the foot plate. When you see that, then you know it's time for the second step. You're going to hoist the person back up slowly, just to take the weight off the cushion. This time you're going to lower the person into the chair, focusing on positioning the person's hips as far back into the chair as possible, without causing any discomfort. So you always want to observe and assess for any tension on the back of the legs, but getting the bum back into the back of the chair, that's the second step. Now, if you do notice pressure at the calves, adjust the leg angle for more negative position, or you start to use a smaller cushion depth if the person's able. Again, every step of this process, watch for that person's facial expression, because we do not want to cause any distress or any pain. Once you have the person sitting in the chair and you watch them relax, this is when you can start adding more sensory information if needed. When you have the person set up in the chair, please bring in the families, bring in the care staff, show them that this is possible. Because oftentimes people will say the person's unseatable, or we can't get a chair to seat them, or they're not able, they're bedbound. Once they see that this is possible, it can motivate people to get on board. Making sure that you're educating staff as you go, making sure that you're educating the family who work with the person, and share all these techniques, the techniques that work, and maybe some triggers that you've noted as well. So this is the transfer into the chair. Now remember, we also must assess the lying supports for bed positioning, because the person spends a lot longer in bed. So we have to make sure it's a 24-hour approach for this to work, because we have to protect the body shape in the bed and in the chair. So I want to share with you a couple of case studies. So a couple of people that I've seen in the last 12, 18 months. And some of the really great results that I found. So this was a lady who resides in a care home, and she sits in this chair for 6 to 8 hours a day. And we can see the way that she's sitting. You can see that she's sliding from that chair. She has no foot support. So the pressure and the sheer force that is being exerted on her body right now, the discomfort and the energy that she must be consuming to just hold herself onto that chair. From the back here, you can see that the trunk is rotated, that the pelvis is rotated, that she's not fully in contact with the chair. So she's not getting that feedback. And then from the front, huge risk of pressure injuries, a huge risk of falls. Obviously going to be affecting her function, her ability to engage in functional tasks. But in the Sorrento chair, you can see she's got full contact from head to toe. She's much more able to look around the room and engage with people, much better able to reach for a cup of tea. Energy is conserved, so she has more energy for those functional tasks. She's fully loaded from the front to the back. And we have them side by side there, the difference that seating can make. So the family noted that she actually wanted to sit out for even longer during the day. There's less hoist transfers as well because she didn't need constant repositioning, and obviously improved engagement in activities. So that was a really lovely case study that I like to talk about because we made such a difference to that lady. And this lady, she had a choice of the armchair or this wheelchair. Neither are meeting her seating or her postural needs. You can see with the armchair, it's much too big, it's much too high, and she's leaning to the side. They have given her a pressure cushion because she was developing some redness and discomfort when sitting in the chair. But by placing a pressure cushion on top of the chair, the only thing that they've managed to do is make her more uncomfortable because they've raised that seat to floor height. And she's also more likely to slide from the chair. And with the wheelchair is great. It's a great chair, but it's just not set up for this lady. You can see that it's not supporting her back. It's not giving her the leg support that she needs. But what I did was I assessed her and I issued her with the Sorrento chair. So you can see with the Sorrento chair, she's much more comfortable. Body's fully loaded from head to toe, and she's even engaging in more functional tasks. I actually couldn't get her to sit still for a photo. And the last one I want to show you is this lady. So this lady has got a diagnosis of advanced dementia, and she's sitting in one of the City Matters Sorrento chairs. And this is a great picture to show you that it's not just about the chair. Now, the chair can be fantastic, but if it's not the right chair, then it's not going to do any good. So this Sorrento chair was given to this lady when she needed it, and it did meet her needs once upon a time. But as we all know, with the progression of dementia, she just started to deteriorate. Her posture began to deteriorate. She began to engage in, I'm not even sure if there's a word for it, is it shuffling? So she shuffles her bottom down the chair. And staff were really afraid that she was going to hurt herself and she was going to fall from the chair. So I assessed her and I issued her with the Atlanta 2. The Atlanta 2, you can see with the Atlanta 2, it has a foot plate and a calf support. So it gives even more proprioception, gives her more sensory feedback. It has a low seat to floor height. And so now in this chair, she has a low center of gravity. So she feels more stable and more secure. And there was no more risk of falls, no more risk of pressure injuries. And that shuffling, that behavior began to reduce, and staff said that she was a lot more comfortable. So as Adele kindly introduced me at the start and told you that I am studying for my doctorate in dementia care and seating. So all this research is ongoing, and I'm hoping to have my own research to be able to present to you in the near future. I'd be really happy if people interested in this area would get in touch and let me know about your experiences, what works for you, and maybe even any way that we could work together. We could maybe set up some clinical trials. Or if you just need my help or support, I'm more than happy. We do have the clinician sitting handbook, which is free. We can send out to you. Please scan that QR code or go onto the website and we can send it to you for free. That has everything to do with seating. It doesn't have the dementia content because that is ongoing, and I think that we will include that when we have it all together. I'm available if you would like to contact me. There's my email. So thank you all so much for joining us. Back to you, Adele.
Thank you so much, Kirsty. That was great. Unfortunately, due to some technical difficulties, we will have to log off at 1:45. So What we'll do is we'll try to even do a couple of questions now. And as Kirsty said, if there's any questions maybe that you would like to ask, please feel free to send to Kirsty's email. I'm sure she'll have to get back to you on anything that she can, or to marketing@a1momentum.com. And if there's anything I can do to help, I will do that too. So we'll just go through a couple of questions, hopefully, if we have time, and then we'll let you all get back to your day. Okay, so let me see here. So there's been a question then, if someone hasn't used the chair in a while, it's sensible to ease back in with some supervision at first to reduce any potential risks. A short supervised session for around 10 to 15 minutes, or how do you go about it? Does that make sense?
Okay, so the question is, if somebody has not been sitting out for a long time, how do you go about grading the activity
Yeah.
so that you can
Yeah.
increase their sitting tolerance?
Yeah.
What I would do is I would sit the person in the chair and assess how they tolerate it. So watch for things like, is there any discomfort, or are they gonna, if they can talk to you, great, they can tell you how they're feeling. But usually I would sit them in the chair for maybe 30 minutes and let them go back to bed, or alternative seating if they have an alternative chair. But 30 minutes is usually a good indicator, usually good starting point, and then gradually increase it over time. But again, it's using your clinical judgment. If you're working with the person, or if the carers, they know them best, so the family, so talk to them and work alongside them to figure out what the best plan is for the person. Oh, but I should really mention, please monitor the skin as well. So making sure that there's no redness or any indications of pressure injuries developing. That's really important.
Perfect. And then just just probably one more is all we'll have time for. This one was, what are your thoughts on use of lap belts or other belt options in seating? And then she just says, I feel like support staff, care home staff often push for the need for them when maybe we don't feel that they're often the answer.
Okay,
Or is that a bigger question to maybe get into another time? Have I to pick the wrong one?
No, that's a great question. It's a great question because I think anyone who knows me knows my position on lap belts. I think lap belts are oftentimes out of desperation. You know, they mean well to put a lap belt on a chair to stop this person from getting out, but oftentimes it's inappropriate to use. It can actually cause a lot more risk. There's a lot of evidence out there to show, you know, that it increases the risks of things like choking, of falling, of injury. So please, if you do have any issues with somebody trying to get in and out of a chair unassisted, and they have cognitive impairment and dementia, it's really important that you do a thorough assessment, and find out what the reason is. Why are they trying to get out of the chair? Oftentimes it's because the chair is uncomfortable. If the chair is uncomfortable, we all want to get out of the chair. And other times as well, it's because they don't have enough sensory information, so they don't feel safe, and they don't know where their body is. So they'll oftentimes try and get out of the chair that way. But using a lap belt is never the go-to answer. There's lots more less restrictive methods to go to first, such as increasing supervision or using sensor mats, or sensor chair cushions. But definitely risk assess before you use lap belts. Really should just be used for transport and for postural supports as well. They should never be to stop someone from getting out of a chair. So if you want any more information, please get in touch and we can have a discussion. And maybe we can do another webinar on that, Adele, if that's something that a lot of people want to know more about.
Yeah, we can definitely get into it. I think we're gonna have to finish up just because I know it's almost 1:45. But again, if you have any questions, please send them through to Kirsty or myself at marketing@a1momentum.com. I'll stick it in the chat afterwards. I just want to say thank you so much for Kirsty for presenting. That was great information. I think everyone's definitely learned a lot. And thank you everyone for joining. Sorry we didn't get through all the questions today, but we really appreciate you taking your time. And please look out for the next webinar. It'll be in your post-webinar email. So I'll send out an email with a link to this live recording. And any kind of resources as well that we could provide, we will. The slides, unfortunately, will not be sent out just because there's some case studies and things that we can't share, but everything will still be recorded and it'll be on the slides on the webinar. Thank you so much, everyone, again, and we hope that you have a great rest of your day. Thank you.